So after all those interesting sessions in the morning by Tilochan sir, so it's a rather simpler topic. I have kept it very simple, and I will talk about SCA anatomy in brief and two cases we have done in our institute. So as you know, the superior cerebellar artery is the terminal. It is the branch just before the bifurcation of the basilar artery, and anatomically it is divided into 4 segments. On the angiogram you can see this is the origin, and from this part up to the lateral margin of the brainstem, it is the S1 segment, that is also called the anterior pontomesencephalic segment or prepontine segment. And then it is from the lateral margin of the brainstem to the cerebellomesencephalic groove, it is the lateral pontomesencephalic segment or S2 segment. And from this cerebellomesencephalic groove, this comes close to each other, that is the S3 segment, and then it is a cortical branch, cortical segment. So yesterday we are discussing a lot about embryology of posterior circulation. Gobinda sir described nicely. So today we will not go in details in that embryology. Just yesterday you can remember this slide. Actually yesterday Gobinda sir explained nicely on the board. So as we know that the yesterday sir was telling ki SCA, ICA are nothing but these are all enlarged elongated basilar perforator. Yesterday he told us, so these are actually the perforator, these are homologous of the basilar perforator. This is SCA. So with this we can explain all different types of variants of the SCA. Like many times we get duplication of the SCA, and sometimes we can get duplication of the ICA. I will show some example. So yesterday this you know that this was described the Jeeper model of the basilar artery. So when it is unfused in the upper basilar part like this, that time SCA may arise from the P1 PCA. This is one variant we may come across. Then 9 different variants have been described about SCA. Like among those, duplication of the SCA is the most common. It is found in the 14%, and rarely it may be absence. And sometimes we are discussing the persistent trigeminal artery yesterday. Sometimes we can see that SCA can be arising from the PTA to distal basilar and ends into the SCA. So that is Salzman type variety of the PTA. These are the different variant we see. So normal course of the SCA, you know that it is just a prepontine segment, then where it is in intimate relation with the third cranial nerve. Because of this relation, you have seen that aneurysm from the SCA in this segment may present with the third nerve palsy. And it also courses, we have seen the lateral part of the SCA, lateral pontomesencephalic segment, it is in close intimate relation with the trochlear nerve. And inferior to this SCA, we see that there is a trigeminal nerve. That's why in our practice sometimes trigeminal neuralgia, we have seen that the SCA can cause neurovascular conflict with the trigeminal nerve, and it is the location of microvascular decompression sometimes when it comes in close proximity with the root entry zone of the trigeminal nerve. So different variant we have I will show. So here, normally what happens, just after its origin, after 18.5 millimeter, it divides into a rostral and caudal division, and then it divides into the cortical branches. This is the normal disposition. So when we see the two different origin of the SCA like this is called the duplication. Then, here we can see the SCA is taking origin from the P1 segment, like when we see there is unfused upper part of the basilar artery. Sometimes common origin of the SCA and PCA is seen, and this is one rare variety where we can see the SCA is taking origin from the cavernous segment of the ICA. So these are the different variants we can come across while doing angiogram, DSA or CT angio. Now I will show you some angiogram picture of different variants. Here we can see this is the left vertebral artery angiogram, where we can see there is a duplication of the SCA on both sides. This is the SCA on both sides. And here we can see in this angiogram, the SCA is arising from the P1 segment of the PCA. Yeah, this we have discussed yesterday in details. Sarah told us about all balance of the SCA, pica and ICA. Like we call it, SCA and ICA are very good friends. So when one is not very strong, the other try to help. So this balance is always there in the posterior circulation. So if you notice this angiogram of the left vertebral artery, where we can see that this SCA is relatively bigger than the contralateral this SCA. So what can be the reason for this bigger caliber of this SCA? If we see this basilar trunk, we can see where is the ICA. ICA is very small on this here. We can see pica here from the V4 segment, and from the basilar trunk we should see one ICA here. But ICA we can see, but it is very small in size on both sides. So because of this small ICA, this hemispheric branch of the SCA is compensating the perfusion of this territory. So this is the balance it is maintained in the posterior circulation. The other side, you can see that the SCA is a normal caliber. Here, though on this side, this is ICA is small, but here ICA is being balanced by the pica. See the pica on this side, it is very big. So another thing you should know that when superior cerebellar artery can also compensate the pica territory. Here in this angiogram, where we can see there is a tight stenosis in the V4 segment incorporating the origin of the pica. Here there is a tight stenosis. So because of this stenosis, we can see there is a large hemispheric this hemispheric branch of the left SCA is supplying this pica territory. So these three friends work together actually, SCA, pica and ICA in the posterior circulation. Sometimes, though rare, we can see fenestration in the SCA. So the branches, if we talk about SCA, is from the trunk of the SCA, common trunk of the SCA, we get perforators, mostly two perforators, and then it divides into the rostral and caudal division. From the rostral division, there are 5 perforators, and the caudal division, there are 2 perforators. So we have to remember, if there is aneurysm or any intervention you are doing in that segment, we have to think about these perforators, because we should not compromise this. We should try to save all these perforators. Otherwise, you know, the supply of the perforators is mainly the brainstem, midbrain and pons. So it can be very bad. So I was talking about branch. So that is the perforator branch. Then it goes into rostral and caudal division, and then it divides into the Vermian and hemispheric branch. And when do anastomosis with the ICA and PICA, in the hemispheric branch does anastomosis with the ICA and PICA. Like other meningeal branches we talk about in ICA, like artery of Bernasconi and cachinnary, all these tentorial branches, difficult name, like PCA, we talk about artery of Davidoff and sector. Here also there is another difficult name to pronounce, actually artery of Ulskliger and Ulskliger, which is actually the tentorial branch of the superior cerebellar artery. So these arteries actually not like other tentorial branch like Bernasconi and cachinnary and artery of Davidoff and sector are not normally seen in the normal angiogram unless there is a pathology in the dura, like dura levi fistula or meningioma or any hypervascular thing. So we don't see this artery of Ulskliger and Ulskliger regularly. But yes, we can try to see in the angiogram. If we do, we can see it sometimes in the delayed parenchymal phase. So these dural or tentorial branches. So here we can see this is the arterial phase where we can't see this branch, but on the delayed parenchymal phase, we can see that there is a small branch which is coming here. That is actually the artery of Ulskliger and Ulskliger, and this is artery of Davidoff and sector. So this angiogram is showing as there is a dura levi fistula. We can see this dura levi fistula main feeder is from the PCA. Here we can see that the artery of Davidoff and sector is very much prominent. Normally we don't see these tentorial branches, but here we can see this is the medial one is the artery of Ulskliger and Ulskliger. So let's come to the SCA aneurysm part. So we know that the different types of location of the SCA we encounter. This is the origin of the SCA. So whenever we face the aneurysm at the origin of the SCA, it can be of three configuration. Type A is that neck doesn't incorporate the origin of the SCA. Type B is when part of the neck, only almost half of the neck is incorporated in the origin of the SCA, and type C is entire neck incorporated within the SCA. So I'll describe two cases we have done in our hospital. So this is one patient. You can see the patient is wheelchair bound, can't walk properly because of severe ataxia, and this patient is having right-sided ptosis. We can see right-sided ptosis. So this is elderly male who presented with bulbar and cerebellar symptoms and right ptosis in adduction restriction. So this patient MRI revealed an aneurysm in the right PCA, and there are some infarct in the right cerebellum. So and it was compressing the brainstem. So when patient came to our hospital, we did as a routine, we do on CT angiogram. This is the non-contrast CT scan where we can see there is a hyperdense aneurysm which is compressing the brainstem, and this is the arterial phase where we can see only this part is opacifying, the rest of the part is not opacifying. This part is thrombosed, and this is the late venous phase also showing there is mild enhancement of the aneurysm, but only this part is opacifying. So most of the part is the thrombosed aneurysm, and it is compressing the brainstem. I think you can see the where it is coming from. This is the video. This is the basilar artery, then this is the aneurysm, and this is another branch. So in the CT angiogram, the reformatted image, we thought it is probably a dissecting aneurysm arising from the P1 segment. That was our initial diagnosis in this case. Then we did a DSA. One screening MR also done in our hospital, which is, you can see, this is the video. These are the infarcts happened in the infarct in the right-sided cerebellar hemisphere, and this is the aneurysm which is compressing the midbrain, and this is partially thrombosed part, and we can see there is some edema in the brainstem also. So we did a DSA for this case. So there is a large dysplastic aneurysm. Again, on the DSA, on the diagnostic DSA, we thought it is arising from the, because of its close proximity with the SCA, we thought it was arising from the P1 PCA. So this is the aneurysm, large dysplastic aneurysm. So 3D rotational angiogram was done during the DSA. So here we can see this is the contralateral PCA. First of all, this is the contralateral SCA, and this is the SCA on this side, on the right side, and this is the PCA. So looking at this configuration, actually, this was not a very good quality 3D rotational angiogram in spite of our great effort. So we can see this PCA is coming out from the top of this aneurysm. Like this is the diagram made by Kaushik. So he's very good at making diagram. So this is the basilar artery. This is the left PCA, left SCA, and right SCA, and this is the right PCA. So we thought it is a large dysplastic aneurysm arising from the P1 PCA. So we planned the case for this, and how we can manage this case option, endovascular option, if I say flow diverter. That is the thing we are talking about, the perforators, because if we do parent artery occlusion, there we will compromise a lot of perforators, as well as it can cause the large infarct in the PCA territory as well. So we planned a flow diverter placement along the PCA. That was our plan. So finally, on the day of the therapeutic procedure, we did the DSA in details, and we thought that there is something wrong with our interpretation. So we went back and saw the base image again on the CT angiogram and the 2D image, and we saw that there is a separate branch which is going behind this aneurysm sac. So we can see two jets from here, and here we can see this is the PCA which is going behind this aneurysm sac. So our diagnosis changed, but we kept our management same, because to protect this SCA, we placed a flow diverter from this PCA to be up to this, covering the entire neck. So this was the flow diverter placement along the PCA. We placed a pipeline vantage 3.5 into 20. So this is the flow diverter placement, and after this we can see there is significant stasis in the aneurysm. So this patient, so just to show you in details about the procedure, this is the diagram where we can see this is a flow diverter we have placed like this, and this is the aneurysm where we can see significant stasis here, and we can see this is the flow diverter which is going, and distally all branches are well opacified. So this patient came for follow-up after 2 months. 2 months, and we can see this patient now can walk very without any. It's not working. Okay, so his ptosis has gone completely. His ocular movements is now almost normal, and he can walk without any support now. So one thing I want to say that here in this imaging part, we have done interval imaging screening MRI, where we have seen that this patient clinically improved significantly, but there is increase in the edema in the brainstem. That's what we are discussing with Kaushiki. What can be the explanation for this? Because initially, whenever there is a thrombosis, it might cause a lot of inflammation. So that is the reason we found there is an increase in the edema even after clinical improvement. That's why people say that don't do any imaging before 1 year. So after placement of the flow diverter till it becomes small. So this patient clinically improved a lot. We are waiting for a. Yes, sir.
SCA is also blocked. So, the right side is SCA. He's saying it is blocked because of yes, sir. The sky. So he's asking whether the right sky is blocked. Do you see any problem with that?
No, right sky is not blocked. It is we have covered the neck and the origin of the scar, but it is not blocked. It is flowing. This is the flow diverter.
No, this is the technique which we call as indirect flow diversion, sir. We are just reducing the flow across the scar, but we have not occluded it.
So gradually it will get occluded.
So the flow across the scar will still remain neat, but it will not fill into the aneurysm that much. So this is called an indirect flow diversion. It's not showing up in the angio, but clinically and maybe the delayed runs are showing the right scar fillings.
You want to?
Because what we have actually in that image you can show. So let's show the next one. No, the previous one, I guess. No, sir. The panels. Can you show the panels? 4 panels, 5 panels.
This one, huh?
No, sir. Next one. Yeah, somewhere there. Once the flow diverter is placed, you can actually see one branch coming off the aneurysm.
Here we can see this is the another branch here.
So the scar is open.
Sky is open.
So even the repeat MRI shows that there is no scar in fact. But what Dr. Gobinda was telling was suddenly we saw a lot of edema and white matter changes in the brainstem. But patient is doing well. So we decided we will not repeat image now till he becomes worse. We don't know what to do with that.
Yeah.
Yes, Gobinda will. Did you give this patient some steroids? Initially, yes, but after that we did not. 2 months
because
later, when he
was, I think, diabetic also.
correct.
So
2 months later, when he was asymptomatic and when we saw the changes, we thought we will just wait and see.
So coming to case 2, so this was again a young patient, 35-year male patient who presented with sudden headache. And CT scan showed subarachnoid hemorrhage, and CT angiogram revealed aneurysm from the lateral pontomesencephalic segment of the superior cerebellar artery. So I don't have much image of this case, but this is the 3D rotational angiogram where we can see there is a large physosaccular aneurysm which is arising from the rostral branch of the lateral pontomesencephalic segment of the scar. This is the caudal branch, this is the rostral branch. This is a large aneurysm, dysplastic aneurysm again. We can see this is the lateral pontomesencephalic segment, this is the aneurysm. So what do you think we can do in this case? Yes. So But one thing we have to remember that though we this is from the rostral segment of the lateral quantum mesencephalic segment of the SCA, and we know that there is also perforator, which at least 5 perforators which come from the rostral trunk of the SCA. So, but yet there is no other option. We can see there is a very small artery. We can't do any reconstructive procedure also. So we thought we'll do a parent artery occlusion, but another problem was financial problem. So coiling was, I think we thought it would be better because sometimes glue can reflux into the basilar trunk or PCA. So that would be safer. But in this case, patient financial problem was there. So we finally we did the case with the glue after the procedure. But patient did very well after that. Patient underwent a VP shunt and all, and after lungs, the patient did very well and went back. So this is our team. Like I said, Pika, and SCA all together. And Arvind is not here. Arvind helped me in preparing all the slides. He's not well today. And Manoj and Vishnu are our fellows, and they are here. So thank you all for.
So any questions on SCA? Yes, Shriram.
Regarding the inflammation part, partially thrombosed aneurysms tend to do that a lot. We actually had a P1 partially thrombosed aneurysm presenting with stroke, and the patient didn't do well, and edema was the principal reason. He also presented with ischemic stroke, giant partially thrombosed aneurysm, FD done with a couple of coils, and that's one of the reasons why I think they were initially putting in a few coils to actually accelerate thrombus. And then kind of they quickly realized thrombus induces more inflammation. And one of the reasons for a giant partially thrombosed aneurysm is also bleeding from the wall. There have been concepts of high dose aspirin being tried for non-ruptured cases. So I don't think, it's the matter of the topography that makes a difference in presentation. Rather than us saying that, not to do imaging. But if it's clinically warranted, I think the message is not to do an image as a routine at 3 months, 6 months, 9 months, and 12 months in case of these FD cases, because we know it's going to take 6 months to 2 years. So, but if the symptom or if the patient has something, and then we need to address it, how long to give the steroids? Is going to be pulsed? Is going to be tapered? I think we still have a lot to do in that front, specifically partially thrombosed.
No, I agree with you completely, especially when we do a flow diverters. I think we should rephrase this. The rephrasing this statement would be, as long as the patient is asymptomatic, you do your images and follow it up. Just because you see something radiologically, they are saying don't jump in. This is not just with MRI or CT. We are seeing this even with DSAs. So what we see is after flow diverters, when endothelialization takes place, we see some stenotic segments inside or just after the flow diverter. Patient is completely asymptomatic. And if you look through case reports, they have actually gone in and done a balloon plasty to that or put another stent inside when actually there's nothing happening. And we had a patient like that with us where we put a flow diverter in I think it was in the ICA. And after that, 6 months follow-up angiogram showed a stenotic segment. Patient was completely asymptomatic. We were discussing whether we should keep our high-dose statins, all that, but we just maintained her on antiplatelet and watched her very closely. And after 1 year, when we did a repeat check angio, that stenotic segment had disappeared. In fact, I'm waiting to see what is going to happen to this guy, because clinically, even the edema that we were talking about, what kind of edema? Is it cytotoxic? Is it interstitial? And if it is an edema, why is it not compressing any brainstem structures? Why is it not caused hydrocephalus yet? We don't know. So what we are seeing is only white matter changes, and patient is completely asymptomatic. I don't know the answer to this question. So I agree with your point that instead of saying that don't do it, we should do it to understand what's happening. But from a therapeutic point of view, we don't need to panic. till the patient becomes symptomatic. So if we see a white matter change, like the gentleman here was asking that do you want to give steroids for this? That I would think twice before giving steroids because patient is otherwise doing well.
Yeah, agree.
I think thank you Gobinda for this wonderful talk. And I don't know all of you. Meaning I've always liked working in a team, and this team is fantastic. Whenever you are in the cath lab, when you have a co-pilot with you who is telling you whether to go ahead or not, it helps a lot. And Govinda has been like that. We have been each other's pilot and co-pilot. So thank you so much. A big round of applause for Govinda, please.